What do most misunderstand about Medicare Advantage as a business model, Medicare Advantage versus Medicare?
I would say the world is divided into good Medicare Advantage and bad Medicare Advantage. Good Medicare Advantage effectively coordinates the care of patients, invests in chronic disease management, does the things that you need to do to keep patients out of the hospital, ultimately lowers the total cost of care, and gives older adults more generous benefits. Bad Medicare Advantage is focused on risk adjustment, which is essentially trying to game the arbitrage between the formulas that the government has in place to actually pay health plans, which pay plans more to take care of sicker people and to try to make a margin off of that arbitrage. They're not doing the intensive chronic disease management, the care coordination that good Medicare Advantage plans do.
What they're really doing is aggregating clinicians and Medicare Advantage beneficiaries, patients, and that's about it.
Yes, and trying to win in some kind of arbitrage. It's really just a financial accounting game for some actors in the ecosystem.
Welcome to Analyzing Healthcare podcast, brought to you by Scale Community. Scale Community is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events, to interactive peer networking opportunities, and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoy today's discussion, please take a moment to sign up for your preferred membership level.
All right. Welcome to Analyzing Healthcare, Scale Community podcast. I'm honored to say that I'm joined by Dr. Sachin Jain, the CEO of SCAN. SCAN, for those who don't know, is the largest not-for-profit Medicare Advantage health plan in the United States, founded in 1977, so it's been a while. Medicare Advantage HMO plans in California, Arizona, Nevada, New Mexico, Texas, and Washington, if my research is correct. 310,000 Medicare beneficiaries.
Almost correct. 310,000 is an outdated number. We're actually now up to about 440,000. So
440,000.
We've just had a kind of an unprecedented annual enrollment period. So here we are.
Wow. Congratulations. That's an enormous amount of lives. Anyone who knows the payer industry knows that is a lot of Medicare lives to be responsible for. And what's just as interesting about SCAN is through your leadership, this payer is no longer a payer exclusively. It's a payer and provider of care, having expanded into home care, primary care, community-based care, all focused on the same core market, the elderly market, with acquisitions and build-outs of different practices across each of those states? Or is the delivery of care component of your business more geographically centralized?
Most of the delivery is in California. There's some in Arizona as well. So we have extended into care delivery, but mostly in our core market, which is California.
That is unusual and amazing. And I can't wait to jump into that aspect of your business.
Really hard, Roy.
Yes.
Really hard, actually. It has not gone as smoothly as we thought it would go. There's a if you build it, they will come mentality when it comes to clinical services, and it doesn't always work that way. So happy to talk about that and the challenges of scale.
You are preaching to the converted, my friend. If we build it, they will come philosophy for about 5 years and then gave up on it because that's not universally true.
It is true for some people. Some lucky people just hang up a shingle and things just start working. I'd like to be one of those people.
Give them time.
I'd like to be one of those people one day. For the rest of us mere mortals, we're just still trying to make these things work.
We're still learning, you and I. Although judging by your resume on LinkedIn, you don't have that much left to learn, I have to say.
That is not true. That is not true. This industry is broken beyond repair. So there's plenty to learn still.
We'll explore that hopefully in the next hour or so. So jumping at the top, 30,000 feet. Medicare Advantage, you've avoided ACA. I interviewed Mark Bertolini, the former CEO of Aetna, the current CEO of Oscar. He went in a different direction, all in with ACA, for better or for worse. You are squarely in the world of Medicare Advantage. What do most misunderstand about Medicare Advantage as a business model, Medicare Advantage versus Medicare? Nobody is deeper in it than you. So if you had the eyes and ears of a very large audience, the US audience, and maybe even a global audience who are fascinated by this. They hear about it all the time, working well, not working well, spending more than Medicare, improving care, a huge success, colossal failure, depending on which side of the aisle you fall on. All these are headlines written by journalists. You're an operator who lives and breathes it on a large multi-state scale. Teach us.
Given the global nature of your audience, I'll take a big step back. Medicare is the program that the federal government in the United States has in place for people who are over 65, disabled, or have end-stage renal disease. It's the insurance that we give to many frail and vulnerable people and lower income and as well as older people. The reality is that this program was intended to protect people from bankruptcy. Healthcare, there was a time when healthcare was bankrupting older adults because they didn't necessarily have coverage. So this was the coverage that was provided to people at a time when the life expectancy of older adults was in the 60s. Today, Medicare is delivered through the traditional Medicare program, which is in some ways also called the fee-for-service program. And then it's also delivered through private entities that contract with the government to provide these services. And the original intent was to more closely coordinate the care of older adults and actually drive down the costs of delivering the Medicare program to older adults. Some 25 years into the history of this program, I would say the world is divided into good Medicare Advantage and bad Medicare Advantage. And I don't want to be overly simplistic, but I think it's important, just for the broader audience to get the kind of stark contrast that exists. So good Medicare Advantage effectively coordinates the care of patients, invests in chronic disease management, does the things that you need to do to keep patients out of the hospital, and over the course of doing that, ultimately lowers the total cost of care and gives older adults more generous benefits. Bad Medicare Advantage is focused on risk adjustment, which is essentially trying to game the arbitrage between the formulas that the government has in place to actually pay health plans, which pay plans more to take care of sicker people, and to try to make a margin off of that arbitrage. They're not doing the intensive chronic disease management, the care coordination that good Medicare Advantage plans do. Now, the real truth is that
what they're really doing is aggregating clinicians and Medicare Advantage beneficiaries, patients, and that's about it.
That's right. That's right.
Pooling as much as possible and then recalculating risk based on that.
Yes, and trying to win in some kind of arbitrage between what the government pays you for the service to these patients and then what it actually costs to actually take care of these patients. And so it's really just a financial accounting game for some actors in the ecosystem. And I would say that the system was largely easy to game over the last 10 to 15 years. And so many so-called good Medicare Advantage plans, because of industry pressures, because of norms, became what I would call bad Medicare Advantage plans. And I would say in the last couple of years, the federal government has caught on to this, and they've introduced a few major changes to try to level the playing field and reduce the cost of administering the program. The most significant of which was a new risk model, which many of us who work in the industry know affectionately as V28. And what V28 does is actually pulls out a lot of the most objectionable and gameable codes, and ultimately resulted in a major decrease in payments to the industry. So there's a federal attempt at this point to try to normalize expenditure across the MA program, which had kind of run away with the traditional Medicare program.
Has this been more like a ratchet, broad brush penalty applied to all the good operators as well as the bad operators, or is this the right step forward?
Well, I think it's not really a penalty so much as like just looking at, the behaviors of plans, and a lot of plans are what economists would call rational economic actors, and if they could drive up their revenues by implementing programs to capture more of these codes, they would do it. And you saw a lot of groups do that. Now, what's kind of gotten lost is the original soul and intent of Medicare Advantage, which was to more intensively manage the care of these patients. And the truth is that many organizations that have gotten credit, I'm not going to name names, just to be clear, a lot of organizations that got credit for so-called managing the care of older adults were never really doing that. And so they're all quite exposed at this point. And so what you're seeing is major commotion and major chaos in the Medicare Advantage industry that was in many ways unanticipated by investors and others who watch this very closely.
And we see it in the headlines. I mean, I'm bold enough to mention names, but groups like United, who have to give back large sums for adventurous coding, shall we say. Or in ACCA, Cigna just announced that it's willing to give back its profits for the ACCA program in the interest of partnership, goodwill, and moving forward. And, part of me wants to criticize those groups for maybe taking advantage, but part of me also feels a lot of empathy for them as well. The payers that participated in new programs.
Empathy for large national for-profit payers. Roy, you're good. It's good. We should all be so empathetic to everyone.
Just interviewed the former CEO of Aetna. Monk is very empathetic. This is a guy who's built his career trying to find value, not destroy value. And I've often found myself interviewing the designers of these programs, whether it's Seema or Mina or Liz, coming out of CMS Innovation, groups that were involved in the actual design of ACCA back in 2008, 2010. And when you put all those pieces together, you consistently find good people who were shooting for a lot of positive changes, cost control, while actually elevating quality and outcome, coordinating care, but who designed systems that weren't perfect. And I think you made a great point, Sachin, which is anything that isn't perfect, it's almost like the market's job to take advantage of whatever it's given, including the good operators, because they can only live within the parameters set by the regulatory bodies. These are the rules. It's almost like tax deductions, right? If it's legal, am I supposed to ignore that tax savings opportunity? And I think for most of us, rational thinkers, you sort of live within those frameworks. So that's where the empathy comes from.
Yeah, I mean, Roy, I'm a big fan of a political economist named Julian Legrand, who asks the question, are people knights, knaves, or pawns? And the truth is most people are pawns. They're slaves to their incentives. I think we imagine them as either knaves or knights. But the reality is that most people are just trying to optimize within the system that they've been given and are doing the best that they can. I will say I increasingly see leadership as departing from pawn-like behavior. And that's where I think we have plenty of opportunity in our industry is we need a generation of leaders who are going to do the right thing, not just do the convenient thing. And healthcare was a profession that was more defined, I think, by people wanting to serve others than they were trying to maximize profits. And I'm not saying that you can't try to maximize profits in healthcare, but what I am saying is that we do need to try to return to the view that this is a service industry first and a source of capital return second. And I think that we sometimes get that wrong. And especially as business interests have really, I think, brought a lot of frameworks that don't really apply to patient care, we've lost our way. We've lost our way. And I don't know that enough people are saying that. And that's where I think we've had a leadership crisis. I think more people need to say that out loud, that we've actually lost our way. And I think, some of the people that we've kind of declared as the heroes of last generations maybe weren't. Maybe they were playing a different game than the one that they should have been playing.
This is the anti-Jack Welch GE argument. I know well, I subscribe to it, which is you can't define business laws by ROE, return on equity alone, and that there's a larger mission at play. So there's no disagreement between us. I mean, I echo what you say. I only have one question. What's a knave?
A knave is like somebody who's
going to try to take,
like a knave, somebody who's going to try to take advantage of every situation for their own benefit, for their own.
That's awesome. All right. So moving forward, because we could dig deeper into commons. Where are the boundaries? Where should those boundaries exist? And I think it is a beautiful topic, especially because behavioral economics, the rational thinking actors, all those arguments that we make when we live and breathe, you and I as operators in that world, we find that the human mind, unlike AI, that isn't necessarily as multifaceted as the human mind, AI is accused of hallucinations. The human mind uses hallucinations to justify most actions. Right? Anything can be justified. If you're a business embarking on a new reimbursement program, and every few years the reimbursement programs are modified, so it always feels new. And here we go again with Medicare Advantage. It's just been rewritten a little bit. So if you're an entrepreneur risking capital, you take your risk, you risk your capital, and you generate returns. And you know that at some point those returns are going to be capped. You know that you're going to lose money in some other program where circumstances run against you. I mean, large payers are I want to say notorious, but I think that's a little too pejorative. But they're certainly widely recognized for making money over here, losing money over there. And the same with health systems, right? Health systems have been
You're describing what I call like ethical erosion, right? It's this
Yes. You can justify anything.
You can
Yeah.
justify anything. I love the way you said that. I love the way you said that, as we can, entrepreneurs almost justify anything. And every day I see people engaged in deep, profound ethical erosion where they are justifying behaviors that if you were to land from Mars, and this is the test, and look at this behavior, you would say this just doesn't make any sense. But people are making it make sense because they have to justify their own existence, whether it's their venture investors or their startup leaders or their large enterprise leaders. And what I'm calling for, and maybe I'm like the lone man in the woods calling for this,
it's always one guy,
is a little bit of an ethical awakening, right? Where we have to kind of call BS on ourselves a little bit. And I was in the prep.
By the way, the guy who does that, or gal, my advice to them, because those are the heroes, right? This is the hero's journey, and the hero's journey is always a very lonely one. Always. My advice to that person is to call it out on a recurring basis, because even if they hear you one time, they're going to need reminders. So I'm really glad.
And the other part of it is we don't often see it in ourselves. Like, we just don't even see it in ourselves. I mean, we're in the midst of, I would say, a contraction in the Medicare Advantage industry. And I've been having conversations with my team about, every dollar we spend on something that is discretionary is a dollar we're not spending on patient care. And I think we have to really look at ourselves and say, do we really need to have our sales retreat at a fancy hotel? Do we really need to, take people to Michelin star restaurants to get their attention about our health plan? And I think the reality is there's been an ethical framework that was applied to the biosciences and biopharma that hasn't necessarily been applied more universally across all of healthcare, which is, let's cut the crap, guys. I mean, if you heard that a pharmaceutical executive was taking people to a Super Bowl box to induce them to prescribe something, you would say that that was unethical. But every day I get invitations to major sporting events from startup executives, vendors saying, let's go do this and let's build a relationship on different grounds. And we have rules around not being able to do that. But I would say the general culture of our industry is a little bit lecherous. I mean, just if you actually have to kind of really think about it.
Healthcare leaders, if your revenue cycle management is underwhelming you, it's time to rethink your current suite of solutions. Scale Healthcare's AI-powered RCM solutions are purpose-built to protect and accelerate revenue across the entire lifecycle. Denial Shield proactively prevents denials before claims ever go out, using agentic AI to automate root cause detection and resolution. Front Desk Shield streamlines preclinical and front-end workflows, eligibility, authorization, and intake, reducing friction before revenue is even created. And Revenue Shield maximizes charge capture and revenue integrity, ensuring nothing slips through the cracks. Together, the Shield suite helps organizations reduce operating costs, capture missed revenue, accelerate cash flow, and increase productivity without ripping and replacing existing systems. If you're ready for immediate ROI and measurable impact, visit scalehealthcare.com and see how the Shield suite redefining AI-powered RCM.
It is the gravitational pull of things. I remember 2015, I was running a lot of surgery centers, and from one day to the next, we went from free lunches for everyone every day to nothing.
Right. And you know what? And people experience that, one way to start with, but long term, when you talk about the trust erosions in healthcare, we should be really looking at ourselves and saying, is all of this spending on all of this discretionary stuff, sporting events, big sales summits, is it the right thing for patients? Is it the right thing for the system? And I think the answer, if we actually were to go to our simpler versions of ourselves, would always be no.
Oh my God, when we perform self-audits, the things we discover, the same thing happens to me in my daughter's bedroom. Wow. I think a 16-year-old girl cannot differentiate between the floor, the bed, the changing room, all one thing. Everything belongs everywhere.
I've seen this room before. I've seen this room before.
Amazing. It is amazing to witness it. Okay, so we're moving forward. So Scan increases top line revenues. I think from 2.7 billion to 8 billion. And you mentioned the membership climbs to 440,000.
Look, we've had an incredible run the last 5 years.
My question is,
Yeah.
so my question, how much of that growth is geographic? You know, you found New Mexico, Texas, and wow, Texas is incredible. I'm so glad I entered that state. How much of that growth is vertical integration? You know, I was doing reimbursement, now I'm doing reimbursement plus providing of care, provision of care, acquisition. How much of it is a function of your roots as a business? Hey, we came out of Southern Cal, and we're about to come out in the next few days with the top 50. That's the wrong headline. Let's fix the headline. With the evaluation of who are the top states for healthcare within the country. And actually, California is going to score very highly, which will shock a few people because of headline bias, right? There's this thing called headline bias where a chunk of our brain thinks of reality based on headlines that we've been offered, not based on the real science or the empirical information, just the headlines. So California always garners interesting healthcare headlines. Oscar left California, right? An example, for better or for worse. So how much of all that growth is the states, your roots, or your vertical integration?
I would say most of the growth is California. We have had significant growth in Arizona, Nevada, New Mexico, Texas, Washington State. You know, New Mexico, we still struggle with membership, candidly. But what I would say is that we have an almost 50-year history now of delivering care and service in California. I would say the big shift in California is that most of our membership was in Southern California previously. Today, you can say we're truly an all California plan. So we have a large number of members now in Northern California. And I would say the drivers of the growth have been a few things. One is we've had consistently high star ratings, which translates into higher revenue for the plan because star ratings are associated with star bonuses. And we pay most of our providers on a percentage of premium. So if you get a higher revenue number from the federal government, you're going to pass on more revenue to providers. And so in this environment of increasingly constrained payments to providers, a health plan that is consistently 4+ stars, as we have been for more than 12 years now in California, is going to consistently pay you more than other health plans. So I think many provider groups are now making the rational choice to narrow the field of health plans that they partner with and partner with only higher star rated plans so that they can benefit from the higher star ratings and the higher star revenues.
And that transition into controlling the end distribution point, the providers. Those providers are mostly in California as well, or they're sprinkled across those states too?
Primarily, we've got large risk-bearing provider groups that we partner with. SCAN is different from a lot of Medicare Advantage plans in that about 90% of our members sit in groups to whom we fully delegate the risk. So we are experts in risk delegation. So many of the criticisms of Medicare Advantage, there's too much utilization management. Well, we don't do very much utilization management because it's actually our provider groups that own the risk, and they are making the choice themselves around what they'd like to.
So these are provider groups that are happy to take on risk. We can manage costs.
Exactly. A percentage of premium, so to speak.
We can map you step for step on the analytics. We'll adjust our own behavior. Give it to us. We want to be grown-ups.
You got it. You got it. You got it. So lots of entities talk about value-based care. Our partners really do it, and they've been doing it for decades at this point.
So if you partner with, I don't know, 1,000 clinicians, 10,000, whatever the number is, 100,000 clinicians, how many of that pie, what percentage do you now control as an owner?
Oh, we don't own, we own very little. We probably employ less than 100 physicians. I mean,
really?
Yes, across all of our groups. You know, we have Welcome Health, Home-Based Medical, Healthcare in Action, which is our street medicine group, and My Place Health, which is our PACE entity, and Embrace, which is our institutional special needs plan that has its own primary care group associated with it.
Excellent. So Healthcare in Action, Welcome Health, Home-Based, My Place. Okay, so the acquisition of residential and My Place. So all of that combined is just a few hundred physicians?
Less than 100, physicians, and probably less than 200 APPs and physicians altogether.
Okay, so it's a tiny percentage of your...
Small. We're planning for the next 50 years, right? I think owning some delivery of care, we believe, is really important in the future for a variety of strategic reasons. But we're not in any rush to get to scale on that. We're just right now, building this block by block, one at a time.
Okay, so it's nice and steady. Slow, controlled pace on the provision of care. Someone should have told Walgreens that.
may have told Walgreens that. I don't want to. I did. I had many conversations with the Walgreens team.
Yeah,
by the way.
they didn't listen.
Yeah, absolutely.
They did not listen. Okay, so it sounds like owning these entities is very instructive, very educational, but not necessarily more than that at this point.
That's right. That's right.
It's not foundational. It's not core yet. Okay, so California, Northern California. I spoke very recently with David Joyner, the CEO of the Health.
Love David Joyner.
Yeah,
He's
great. Incredibly highly viewed. He described this year using Queen Elizabeth's term annus horribilis.
I don't know that term.
That's how she described it. I can't remember what year, but that was the year that Windsor Castle burnt down. She lost a lot of her art. That was a bad year. Many other things happened I'm not even going to bring up because they're so painful to a former Brit. Annus horribilis. So he said, look, yeah, we're seeing Medicare Advantage cuts. We're seeing Medi-Cal cut. We're seeing whatever we have in ACA cut. And so we hit, I'm not going to name it, but we hit meaningful scale revenues. And now it's massive steps backwards. And I'm supposed to make sense of this year and make investments. How would you describe this year, hearing all of that? Because sometimes lowering tides actually reward the best operators.
Well, that's kind of how it played out for us, candidly, Roy. I mean, our company historically grew 20, 30,000 members in every annual enrollment period. This last annual enrollment period, we grew 127,000 members.
So my thesis might have some merit here, that it's not necessarily a disaster. You need to look at the year in retrospect, the end of the year, to really know for sure. Just because it's a difficult environment doesn't mean a good operator can't outperform. Tell me about
I also think you don't know if something is, if growth is good growth for a few years. Yeah. I mean, I can tell you, we feel very strongly that our growth was good growth. I can tell you that many of the other Medicare Advantage operators who grew this last year are pooping their pants, to use a technical term, Roy, because they now have to manage large numbers of members across vast geographies where they don't necessarily have a lot of the levers that they need to have to control total cost of care.
Or even provide service. This is another theme that I've studied, seen examples of recently, of networks that are not really as available or built out or even real as the given payer represents that they are. And eventually those pigeons come home to roost.
Always do. They always do. They always do. And you saw that, right? Many plans offered rich benefits a few years ago. They oversold. The cost of care went through the roof. They then exited markets. They cut benefits. Other plans picked up that membership. So there's a little bit of a game of hot potato that's being played right now. And so I think we're just navigating all those headwinds. I
have a good friend who I've witnessed. He's quite a Don Quixote character. He left a cushy, low-risk job to go and launch a payer in Texas, first member. And he's hit 10,000 members this year. This is about 5 years later. So maybe 6 or 7 years later. So it's happening.
Medicare Advantage?
No, he refused to participate in any government programs whatsoever. It's all employer self-insured.
Wow, cool.
Yeah. I'll introduce you. He's an interesting guy. We just had sushi together. Fascinating guy. All right. So you just partnered with Sutter Health. Tell us about Sutter Health.
Look, Sutter is an extraordinary organization. It's grown tremendously in Northern California. You can't drive a few miles in Northern California without running into a Sutter facility. They're really seen as the premier provider in Northern California. About a year and 2 years ago, they came to us and said that they were interested in potentially launching a joint venture around Medicare Advantage. They're led by a tremendously visionary and bold and fast-moving CEO, really atypical in the health system space, a guy named Warner Thomas. And we got to work with him and his team. And in our first year, we have 20,000 plus lives with Sutter. So it's been a tremendous partnership, and it's only going to grow from here. So we're very, very excited about that relationship.
You would think that a payer is in a ideal position to pick best-in-class providers of care?
Potentially. I mean, it depends. I mean, I don't think that's necessarily universally true across all geographies and all markets. I mean, I will tell you, in some of our non-California markets, if a payer doesn't have a chunk of membership, it's hard to even get a meeting with,
Yeah.
and much less a contract with some of the provider groups, because there's a chicken or the egg problem. Like if you don't have membership, they're not interested in having you. But if you don't have them, you can't necessarily get membership. And
Market
so
dynamics. True.
so it's very different across different markets. I think, Sutter and Scan were a natural fit together, both not-for-profit organizations with.
I was gonna ask, is your bias to try to partner with non-for-profit, given that you are non-for-profit, or do you not view it through that lens?
Look, I think, in healthcare, there's real not-for-profit, or to use an analogy I used before, there's good not-for-profit and bad not-for-profit.
I love how you do that, by the way. It's very helpful. You're reductive to the point of even someone like me keeping up with you.
So, I mean, the truth is that there's for-profits that act like not-for-profits, and there's not-for-profits that act like for-profits. And, what we're bound by, though, is really trying to do the right thing and, on the margins, make decisions that are pro-patient as opposed to pro-shareholder. And again, those things don't always have to conflict, but oftentimes they do. And so I think we were really excited about the relationship with Sutter because of the shared values across the two organizations.
Okay. So great strategic partnerships. You're loving what you're doing. I want to double back for a second on CareMore and Aspire and Anthem, because I can't let you off this podcast without delving a little bit into those experiences.
Yeah, it was an extraordinary chapter of my career. So happy to talk.
Yeah. But I do want to ask for our senior care listeners who are worried, and for those who can see the beginnings, the outline of senior care approaching, I sort of raised my hand. I'm one of those people. Turning 50, it's coming.
You got a long time. I mean, you may get an AARP card first, but yes.
Still,
you got plenty of time.
I worry about everything. So, I'm aware of this country.
You're a New Yorker.
I'm a New Yorker, and I know that the Medicare doesn't really cover long-term stays within nursing homes. That's a Medicaid program. I'm worried about loss of funding. I'm worried about the wave that's coming, that's here. I'm worried about healthcare stability. And so I'm a senior care listener. Why should I be excited for the next 15 years? And what's going to go well for us?
Well, I think, we're entering a period of the creative destruction of the U.S. healthcare system, I think. I think we are in a period right now where everyone's finally looking at the amount of resources that are being poured into healthcare and are just now saying it's not making sense. Now, I listened to a Don Berwick podcast a couple of weeks ago, and he was talking about how people had the same realization in the 90s when GDP was devoted to healthcare was 7%. Today, we're at about 20%. So, these things come and go. But I think we're at a meaningfully different point where people are crying uncle and saying enough is enough. And there is a fundamental reconsideration of basic things that we've accepted for a long time in healthcare, like where healthcare gets delivered, how much should it cost, the role of consumers versus the role of intermediaries in the delivery of healthcare. You've got a lot of people preparing to run for office in 2028 who are making big pronouncements about healthcare. You're even seeing President Trump make big pronouncements about healthcare. He announced the big beautiful health.
How do you tackle inflation without talking about premium rates?
Exactly. And I mean, the truth is that, if you talk to a plumber these days and you say, hey, why did your price go from 120 to 220 for an hour of service or half an hour of service or whatever the unit is, he would tell you that he's just trying to, pay for his health insurance premium because the subsidies have expired. And so there's a boiling crisis in our society right now that's going to force us to rethink a lot about what we do and how we do it. And I think that there's going to be a Manhattan Project around this, many Manhattan projects around this, and very different from previous Manhattan projects. I mean, one of the first was like Steve Case launching Revolution Healthcare. I don't know if you remember that. It was like
there aren't that many projects going on here.
$250 million in 2000 business school. It was 2005, and the big headline was that Steve Case was going to change U.S. healthcare with a $250 million.
Oh, I remember.
Investment.
Yeah.
Right?
And I've spoken to a few of the institutions involved in that partnership.
Yeah. But I think
that was just an example of a headline. Yeah.
Right. But I think it's going to be very different the next couple of years. And I think we're going to start making different choices as a society. And
you've got some reasons for optimism. I know Dr. Oz, the CMS administrator, recently in Davos, his forecast was we can find $200 billion of waste in healthcare just using AI analytics alone. Okay. So, they're setting
one man's waste is another man's profit.
there's a lot of truth to that, it's easy to call waste. Some of it, certainly the fraud, but these things do take time and they are hard to unpeel because everything is connected. But I do think these are exciting times. So, okay, so you think there's going to be a creative destruction. I go back to my question. At the end of all this creative destruction, what am I left with as a senior care citizen and patient? What can I look forward to?
I think you're going to find 15 years, you are going to age into Medicare. You're going to enroll yourself in a plan. It's going to cover most of what you need to cover. And there's going to be a much greater focus on keeping you healthy and reducing the volume of services that you require. I think we're still stuck in the Lyndon Johnson version of Medicare, which is like, when you get sick, we pay for it. And I think what we need to do is evolve towards the newer version of this, which is, we don't want you to get sick in the first place. And you can address healthcare costs two ways. You can like change the prices and say it just costs too much, or you can reduce the volume of services that are actually delivered, either through brutal means like utilization management, or through kind means, or like kind means, which is actually focusing on keeping you healthy so that you don't need dialysis and you don't need, retina surgeries, and you don't need expensive drugs for conditions that could have been prevented. That's the world we have to get to. There's a world we can get to. I believe we will get to it, but it's not going to be without some pain and stress in the US healthcare system.
Always pain and stress, but I agree with you. The silver lining is
Roy, you've got too many miles on your 49-year-old body. That's all I'm going to, I don't know you that well. I don't know enough to say that to you, but it feels like you and I share something, which is in a short period of time.
I pain and stress at age 1 when my older sister stole my toys. Lots of pain and stress. All right. So before I let you go, CARE, Aspire. So CARE, primary care, value-based care, delivery of care.
And a health plan.
And a health plan
too. Yeah.
Aspire, home health, and Anthem. I think one of your earlier tastes of large payer and the insurance, the underwriting side, which became Elevance. So when you take those experiences together, how do you bring pieces of that into what you're doing today at SCAN? How does SCAN benefit from that?
CARE was a very, very special organization. It had just been acquired by Anthem. And so I spent 5.5 years as the leader of that organization. As much as I gave that organization gave me more. It taught me a philosophy of care that still defines my approach to how we address care for patients. And, it's fundamentally about, number one, respecting people in the context of their lives. Number two, making sure that they have access to high quality services that are really focused on like ensuring that like bad things don't become horrible things. We just have a way in this society of just like, letting bad things become horrible things. Diabetes becomes dialysis. Hypertension becomes heart failure. Bad diets become strokes. And CARE was ultimately about like, how do we reverse those things? How do we make those things happen less? And so it really taught me a philosophy of care. I think one of the missed opportunities, candidly, and I still think about this a lot, is CARE should have almost been a reverse integration with Anthem. I mean, if Anthem had acquired the entity and then taken the CARE view of the world and applied it to everything that Anthem did, it would have fundamentally transformed Anthem into something more than it has been.
Teaching an elephant to dance.
Yeah,
Same thing happened to Mark, where he came from one payer that danced and joined another payer that refused to dance. And so he hit a cultural wall there. And the same thing has happened to me speaking to a few CEO operators of hospital systems that have merged smaller systems into larger systems to find that, it's no longer nimble and no longer able to be truly rational. It becomes a thing into itself, right? The structure determines outcome as opposed to the goal.
Absolutely. And the other thing is oftentimes companies don't know what they've actually acquired, and they don't take the 5 minutes to really understand it. And
we're seeing it now in the medical distribution space. I have it on good intelligence that Cardinal doesn't actually know what it just bought in terms of provider.
so that
they're asking, what is this?
Yes. And again, I think people see the same words and they don't see the fact that the same words in a medical group context mean something very different in a health insurance context. And so we oversimplify things and we don't respect nuance. And so I think, The work ahead is to really respect nuance. The work ahead is to, really learn from vanguard organizations and try to bring those lessons to more people. And that's the thing I'm excited about for the next phase of my career.
I'm going to end by declaring that I respect your schedule. And so I'm going to let you get back to it, Sachin.
Thank you, Roy. Great to spend some time with you.
Oh my God, yes, I will insist on that. So thank you again.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.